Hello everyone, my name is Brandon Platt. Thank you for taking an interest in my applied research project. This presentation is entitled Testicular Fracture in an NCAA Division I Baseball Catcher, a Case Study, and it is presented in partial fulfillment for the requirements for the degree of Doctorate of Athletic Training. Testicular injury is rare, encompassing less than 1% of all trauma-related injury. 21% of all testicular injuries reported in males aged 12 to 24 occurred while participating in baseball. However, similar studies have reported the testicular injury rates as low as 0 per 1 million athlete exposures in baseball players. Even with such a low prevalence, early recognition and identification of such injury is paramount to prevent long-term damage. Atrophy can occur within 6 to 12 hours of disrupted blood flow, potentially leading to issues such as infertility, hypogonadism, and/or chronic pain. The following is the case of a 21-year-old junior catcher on an NCAA Division I baseball team. Prior to the incident, he had no known history of testicular injury or disorder and was wearing a protective cup while catching. The injury occurred when the athlete was struck by a foul ball to the groin area during Game 3 of 4, Week 1 of the 2018 season. Initially, the patient reported that it felt like he had a bruise causing tightness in his medial thigh. He had no direct testicular pain to report and was not experiencing any nausea, vomiting, or pain radiating into the abdomen. Over the next 30 minutes, the athlete complained of increased pain in the right testicle and stated that he felt like his scrotum was becoming more enlarged on the right side. The athlete was removed from play prior to the top half of the ninth inning, and he was brought into the locker room for further evaluation. There was palpable enlargement of the right side of the scrotum, and the right testicle itself could not be properly palpated due to increase in swelling. During this time, the athlete admitted to increased pain and radiating symptoms into his abdomen. On this slide are the 4 differential diagnoses identified for the case. Column 2 describes the common symptoms of each pathology, and column 3 describes the red flags that could indicate the need for referral. It's important to note that, in each case, there are many similarities, making diagnosis difficult. This, in turn, requires the athletic trainer to recognize the red flags involved and make the proper referral to limit the risk of long-term damage. Please take a few moments to familiarize yourself with this information. Following initial removal from play and evaluation, the patient was monitored for the remainder of the evening, instructed to use NSAIDs every 4 to 6 hours with ice, and support the scrotum throughout the evening for comfort until he could be reevaluated the following morning. When there was no improvement following the first 8 hours, the athlete was referred for further evaluation. The initial referral upon follow-up examination by the athletic trainer the following morning was made to the emergency department, where a diagnostic ultrasound confirmed that there was no compromise of blood flow. A follow-up ultrasound was performed the following day by the patient's primary care physician, indicating a fracture of the right testicle. The patient was immediately referred to a urological specialist, where a surgical repair was highly recommended. Here we see the return to play progression developed by the athletic trainer in conjunction with the urologist and primary care physician in the absence of an available established protocol. The athlete was on complete rest from athletic activities from days 0 through 13 in order to decrease pain and swelling while allowing the surgical incision to heal. The athlete was allowed to return to activities of daily living as tolerated during the initial period of rest. From day 14 through 17, the athlete was allowed to complete an accelerated return to athletic activity as symptoms allowed. As one can see, each day consisted of multiple activities, each increasing in sport specificity, intensity, and risk of re-injury. For example, the athlete was allowed to begin throwing and hit off the tee prior to taking batting practice. He was allowed to catch and take ground balls on day 14, but was not allowed to block balls in the bullpen. This is in contrast to day 15 and 16, where the athlete was allowed to increase his throwing distance, catch bullpens with blocking, catch live pitchers with hitters to build confidence behind the plate, and hit live pitching. Day 17, post-surgery, the athlete returned to full, unrestricted return-to-play activities. All told, the athlete missed a total of 20 days from the initial injury to return to play. Literature indicates approximately 45% of blunt force scrotal trauma cases result in testicular rupture, dislocation, or hematoma with rupture, putting the patient in the minority. Half of all cases of blunt force scrotal trauma are sport-related, but as stated earlier, the risk of testicular injury in baseball has been shown to be as low as 0 injuries per 1 million athlete exposures. In addition to the uniqueness of injury, another challenge faced was the fact that published return-to-play protocols specific to testicular fracture in baseball could not be located during the literature review process. Therefore, the athletic trainers and physicians designed a plan based on tissue healing properties, patient comfort, and necessity for time of the season while allowing the patient to return to activity safely. The patient was allowed to return to play when his symptoms had resolved, he had completed the progression, and all surgical incisions had healed. This case illustrates the importance of the athletic trainers to be prepared for any situation regardless of practice setting, uniqueness of injury, or how low the risk of injury may seem. This case will allow athletic trainers to recognize signs and symptoms of testicular injury, assist them in making proper referrals in the event of scrotal trauma, and help future professionals design and follow stepwise evidence-based return-to-play progressions following testicular fracture and repair. Thank you very much for taking time to listen to my presentation and to review my applied research project. I hope it has helped advance your knowledge on testicular trauma and will help you in your future clinical practice as you need to make referral and return to play decisions.